All right. Yes. So yeah, sorry about all of this. Yeah, yes, it's technology when you're trying to connect two continents. Thanks a lot for the yeah for the invitation. I'm super stoked to do a presentation on the snowflake medicine. I wish I could do it in Icelandic, but yeah, that's yeah, it's going to be in English. Sorry about that. So yeah, my name is Eric. I'm one of the emergency physician. I was in Iceland for 5 years, and today I was invited, yeah, to talk about first help and avalanche victim management. Um, so yeah, the goal is just to talk about first aid and also medical management. My understanding is that you are mostly non-healthcare professional. Yeah, so I'm adjusting my presentation for you. Let me know if things are not super clear or too complex or not enough, and then we can also go much further if you want. So why am I here? Yeah, tonight. I guess it's just a long chain of event, but uh, I was involved when we had the case of an avalanche victim in 2020. Yeah, so very sad event, and it kind of shook me inside in many ways. And then I just realized after that that well, I like outdoors, I like cold, I like mountains, I like snow, and yeah, at some point you're just going to be in contact with avalanches. And in fact, yeah, I was lucky enough to have escaped Everest Base Camp just a few days before there was this massive earthquake and the avalanche that swept the base camp. I was just yeah there like I think 5 days before. I had some friends there, so very tragic event. Um, and and yeah, and but closer to you in Iceland, and I don't have to tell you that because you're the expert of avalanches, but uh, avalanche is really a part of, I would say, it's very a part of the country, such as glaciers and volcanoes. And to me, it was not super clear my first few years in Iceland how much avalanches there were in Iceland. To me, I was more into the stereotypical kind of like scenarios of avalanches with skiers and snowmobiles. But then I realized there was a vast history of avalanches in Iceland, very tragic history. Um, and also kind of like keeping up with the news still in Iceland. I was very surprised at some point to see that, yeah, there's like this 10-year-old kid who was saved of an avalanche. And it seemed like a very benign event, just playing outside of his house with his brother. And then, boom, got swept in an avalanche. This could have been very bad. Um, so yeah, so that made me realize that yeah, avalanches are a bit everywhere in Iceland, not only for the skiers. So going back to the avalanche medicine, what I want you to realize, and you probably know, is that when you're dealing with avalanche victims, it's very a race against time, and it's going to be a difficult race. The mortality rate is higher than any other topic that I presented for wilderness medicine or any other conditions in medicine. Um, and it's really a race because yeah, someone is buried under the snow and they are lacking oxygen. They're gonna suffocate at some point, or if they have any severe trauma, we have a bit of a window to find them and treat them. So this is kind of like an all-in rescue when you guys are involved. And the big number I want you to realize is 10 to 15. So it's 10 to 15 minutes is the time you have to find someone who is critically buried. So that means the head and the chest under the snow to have good chances of survival. At 15 minutes, if someone is critically buried, they have a chance of survival of about 90%. And bad news for us, there was a recent study from Switzerland who showed that this line is actually maybe more 10 minutes for them. So we have 10 to 15 minutes to find someone with good prognosis. Um, and to help you understand this, this is a graph of the survival probability on the y-axis, and on the x-axis is the duration of burial. So this is from 3 countries, Canada, Austria, and Switzerland. A bit different, but kind of like showing you the same tendency. You can see basically from duration of burial at 0, it's basically a big downhill slope until 40 to 60 minutes. Okay, so when someone is critically buried, 10 to 15 minutes, they still have good chance, 90%, and this drops down like severely to about 30% at 30, 40 minutes. Okay. So that means that even though you guys, I find in Iceland, you're super well organized in terms of like the Björgunarsveit, even though if someone gets the call, gets to the casern, the base, and goes there, it's probably going to take more than that time. Okay. I know you guys have good response time, but still, I just want you to realize that this is kind of like what's going to save this person most of the time is the people around them. And then there's a bit of a flattish line after 30, 40 minutes, and the survival is a bit stable. It's because these people who basically have died from suffocation and trauma in the first 30, 60 minutes. After this, it's going to be more hypothermia, who's going to be the cause of death. If at any time you guys have any question, let me know. I don't see the chat because I have some screen problems.
Eric, can I mention one thing? So the slides are sometimes a bit blurry. I don't know if it will help if you turn your camera off or something. We can maybe try it.
Of course.
But yeah, I think it's still like a Mac, the same problem with like MacBook and sharing screens with a lot of people.
You're mute, Eric.
Oh, yeah, I mute my. So, all right. Do you still see my screen?
No, I don't see it.
Okay. Okay. Do you see my slide?
Yeah, we see. Seems similar though, like back and forward blurry.
Oh, that's bad.
I can also, if you want, I can throw them up. But yeah, it's bearable. It goes back and forward, but
okay. Is it still blurry? Yeah.
Yes.
Yeah, it's like forward. I can also throw them up if you want.
Okay. Yeah. Yeah. I mean, I think the slides are a good adjunct, but
Já, spurning Thomas, hvort þú deilir bara svo þetta verður skilja.
Já.
Það er snöggvast. Já.
Do you want me to go back a bit or?
Skjáin, yeah.
Yeah. No, so you can just continue, Eric, from where you were. I think it's okay.
Okay. Yeah, so yeah, basically this is kind of like the graph that is important to understand kind of like the rationale between, for the management of avalanche victim. All right, the next slide. So the causes of death are going to be mostly asphyxia, trauma, and hypothermia. Asphyxia is going to be most of it. It's about 70% of causes of death for avalanche victim. Trauma, 5 to 20%, depending on the studies. And then hypothermia, even though we talk a lot about hypothermia, it's still about less than 2% of the causes of death for avalanche victims. Next slide. So there's basically kind of like 3 ways of asphyxia to cause death in avalanche victims. The first one is maybe the more obvious, is that when someone is buried under an avalanche, a lot of snow, and then they would have a lot of snow under their on their mouth, and this would block the airway. Okay, and that can also block the front of their face. The second cause of death is just kind of like blocking the recirculation of oxygen. So their airway would not be blocked. They would have a bit of an air pocket, so a bit of oxygen because they block their face, or they have an avalanche airbag. But as the time goes, they're kind of like breathing in the oxygen and breathing out the carbon dioxide. And then at some point, the oxygen level is going to go down, and then the carbon dioxide is going to go up, and then they would suffocate from that. The other way is just basically more like a mechanical way, is because they're buried under an avalanche. Their chest is basically blocked, and they cannot breathe in and breathe out because of this kind of like mechanical blockage. Next slide. So yeah, this was basically just the oxygen and the carbon dioxide. And next slide. So basically asphyxia is a race against time. I mean, lacking oxygen is not good, and we want to go there as fast as possible. And why is this so important is because there was, as of now, in the medical literature, there has been no case of survival if someone is under the snow, head and chest, and that their airway is packed with snow. Okay, so basically they're gonna die from asphyxia. So no case of survival more than 35 minutes if their airway is packed with snow. And the thing is that we just don't know. I mean, maybe that person was lucky that you're gonna go and to them, and then their airway is gonna be open. But since we don't know, we just have to race against this time and find that victim as fast as we can. Next. So, I mean, there's a few things we can do, but most of it is just to get there fast, localize the victim with the beacon or the RECO, like the previous presentation. And then after this is going to be to liberate the airway and the chest. And if you ever find someone there, it might not seem like a big detail during a rescue, but it might be a big detail for us later on in the hospital, is if their airway was packed with snow. Did they have an airway pocket? Yes or no? Because for us, it's going to help us prognosticate this patient. Next step, next slide. If you find someone who is in cardiac arrest, so you're gonna have to do a CPR. We say to start with 5 ventilation, and then you can do your 32 compression and ventilation. If you have an AED, you can connect it to the patient. Next slide. One of the questions that was asked as a preparation was also when not to start CPR. And I would say for someone who's more knowledge into first help, I would say this is a tough question because you might not know, this person might look dead, but maybe we can do something in the ER or vice versa. But the kind of like the general rule is that if someone has a trauma not compatible with life, that would mean, someone who's like critically sick with very obvious trauma that you cannot survive, I wouldn't do any CPR. And also rigor mortis, which is a medical term to say that someone who's so dead that they're basically kind of like frozen or stiff. That would be the word, which is a bit tricky because if you're talking about an avalanche victim, they might be cold, so they might be stiff because of this, because of the hypothermia. So in any case, if you don't know, I would say just start CPR, and then we can kind of like, you could always try to call someone in the ER or someone, a paramedic, and then they could make a decision. Is it clear so far?
Yep.
Yeah, all right. Perfect. Next slide. So trauma. I mean, trauma is going to be a big part of the management of avalanche victims. I mean, I wouldn't expect someone who to do first help on a major trauma and save them. But a lot of time what would happen is that someone would not die in an avalanche, and then they would be bruised here and there. And this is, I think, where we can make a big difference. Like I said, it's about 5 to 20% of the cases of death. And most of the traumas are to the head, neck, the lumbar spine, the thoracic spine, the chest, and also the peripheral limbs. I mean, we could say, oh yeah, this person is just kind of like falling under the snow, but I mean, snow is hard, and also sometimes they hit rocks or trees or cars, or maybe they were in a car and the car flipped. So there's most of the time a big trauma component to the avalanche victim. And next slide. Yeah, so this is basically just what I said. Next slide. So if you see someone who's a victim of a trauma in the wilderness, couple of things. I think the most important thing is probably just to stop the bleeding. If there's any like massive external bleeding, the first step is always just to compress on it and stop it. Also kind of like oxygenate and make sure that person has enough oxygen to perfuse their body would be good. So again, liberate the airway, remove the snow. You could always reposition the jaw to help them breathe. If there's any obvious trauma, yeah, you can take a direct pressure. There's also about if there's any like massive bleeding that is not stopping with direct pressure, you could always use a tourniquet, but I wouldn't necessarily expect someone to carry a tourniquet in the wilderness. And also, I think this is where it becomes important, also as of triage, is to do a good head to toe sweep. So maybe if you're, I don't know, you've done first help, but you see someone who's quite like a bruise, from I think just to palpate their head, kind of like what we do in the ER, also just to kind of like use our hands and kind of like look at the head, look at the spine, palpate the chest, the shoulders, kind of like one limb at a time. And this is kind of like gonna help you evaluate how sick is that person or how many injuries do they have. It doesn't mean you need to undress them under snow. Obviously, we don't do that unless it's for a very critical condition. But at least kind of like evaluating the victim, looking at their legs, they might be like on a snowboard, on skis. These are quite stiff, so they might have broken a leg. And then splinting is going to be a very big part of it. Next slide. So when you do splinting, basically just the term to say kind of like to immobilize a limb. We try to immobilize the limb in a neutral position. That means what we would expect that limb to be on a normal day. And this is where you can become quite creative. There's some commercial splints, like Sam splint is the most popular. But you can basically use anything you want, tire trip from mountain biking, ski poles, and then just kind of like wrap it up for most of the time it's going to be the arm or the shoulder that's going to be painful, or the leg. Next slide. So yeah, so what I forgot to mention is that when you're doing splinting is basically if you're evaluating someone and you're thinking they might have a fracture, you're splinting them so they are not kind of like wiggle their arm around, and this is going to be painful. So the first reason is going to be to decrease the pain, and also since they're splint, they're moving less, so their fracture, if it's unstable, it's not moving and it's not going to make any pressure or swelling, which can increase pain, of course, and also do any damage to the nerves or to the arteries. Okay, so splinting would be kind of like, I would say, a big role that you can do. But there's a caveat. The caveat is if there's any open fracture, this would become quite an emergency, and this would require a rescue, a very fast rescue. So an open fracture, what it is, well, it's if there's any a fracture, you suspect a fracture, and then you see blood or bone. Okay. I mean, this is an emergency because if it's not treated well, if it's not clean with antibiotics and surgery within a certain time, there's a risk of infection and kind of like long-term complication. Most of the time, what it's going to look like when there's an open fracture it's going to look bad. There's going to be like a affluent, like a deformity, and then you're going to see blood and bone. And this is where it's important to do a good head to toe sweep, even though the person is, with their mittens and shoes and then like ski pole, ski boots, just to kind of like do a good evaluation, because it might not be obvious that there's a fracture. So if you palpate them and say, okay, their left knee or leg is painful, then I'm going to only maybe undress that part and make sure it's not an open fracture. So this would kind of like warrant an immediate evacuation. And let's say someone you suspect that is not an open fracture, they look pretty good, you splint it, I think that they need to see medical care, but this might be a bit less urgent than an open fracture. If you suspect an open fracture, like I said, this is an emergency, and what you would want to do is to cover it with something that is as sterile as you can find in the wilderness. Splint it. I wouldn't expect someone in the wilderness to reduce them, but at least splint it maybe in the position that you find it. This is going to be extremely painful. So if you have any like paratabs or ibuprofen, you could always give it to them and get them out as soon as possible. Next slide. Another major part of trauma management is going to be the spinal motion restriction, which has changed a lot I would say like in the last 10 to 15 years. We used to put cervical collar on everyone who was in a trauma. Now we're talking about moving away from the collar and just kind of like making sure they're not moving their spine. So the spinal motion restriction, and this can be with a cervical collar, but it can also be with just bags, evacuation mattress, and usually these people would have some pain in their neck. Pain if they move their neck, then I would warrant a restriction. Where it's a bit more tricky is that when people are unconscious, this is where they cannot tell you if they have pain in their neck or no. So if someone who's awake and talking and they look pretty good, they were like in an avalanche, but they look fine, they don't have any neck pain, then they're okay. We don't need to immobilize them. But someone who would be unconscious in a trauma, that's something I would recommend at least making sure their head is not moving everywhere and kind of like immobilizing it. Next slide. So hypothermia is something we talk a lot, but like I said, it's about less than 2% of the causes of death in avalanches. But I think it's quite important to talk about it, because even though it's not a very big cause of death, it's a big cause of comorbidities in someone who is still alive during a rescue, because we're going to need to address and making sure they're not going to go into hypothermia. We have studies that shows that it takes about an hour under the snow to take your core temperature from normal 36 degrees to about 30 degrees. So since it takes an hour to go down, we say that if you die within an hour in an avalanche, you probably didn't die of hypothermia. But after an hour and a half, this is where, if someone has been buried under the snow, this is where hypothermia can become a very big problem for that person. So if you find someone in cardiac arrest within an hour, they probably didn't die of hypothermia. If it's been more than an hour and let's say they had an airway that was open, no snow in the mouth, they look like they didn't have any major trauma, then you might think that this person died of hypothermia. But they need to have their airway open, so no snow in their mouth. Next slide. So this is what we call the revised Swiss system for the hypothermia grading, because I forgot to mention, but hypothermia is when your body temperature is less than 35 degrees, but we don't measure this in the bush, in the wilderness. So we kind of like have to assume that what the body temperature of that person is. And I think the best is the best way, one of the best way to estimate it is what we call the revised Swiss system. And we used to say, okay, how that person is awake, or is he confused? Is he shivering? Yes or no? But now they've really simplified it to, I would say, like the most simple way, which is how awake is that person. So if you are more than 35 degrees, you should be alert unless you have any other injury. Between 32 and 35 degrees, again, you should be alert. So that means would be someone who's talking. They might be a bit confused. They might be a bit slow, but they're going to be alert. They're going to be awake. Between 28 to 32 degrees, we say that of core body temperature, that's about, they would say, they would be verbal. So that means they might be a bit confused, they might be a bit sleepy, but if you ask them to wake up just by verbal, just, hey, can you wake up? Are you with us? They're going to open their eyes. Okay, they're probably going to be confused at that point. If they are 24 to 28 degrees Celsius, which is quite low, you know, this is where they becomes unconscious, or they only wake up with pain. So they would be like lying down on their back, looking unconscious. And then if you shake them only, they're going to show signs of life and wake up. And they would still have a pulse. And it's only when they're less than 28, 24 degrees Celsius that they're going to be unconscious, not waking up, but no pulse if you measure it. Why is this important? Is because when you become into the 28, 30 degrees Celsius, this is where your body is at risk of going into cardiac arrest or arrhythmia from hypothermia. Okay, so this is kind of like the danger zone for that patient. Is it clear? Yes, I assume so. So yeah, so like I said, hypothermia. Next slide. If you have hypothermia, cardiac arrest from hypothermia, meaning no pulse, it's usually more than 60 minutes with their airway open. Next slide. So yeah, this one. So there's two things that are important with hypothermia for avalanche victim, and also I would say also in general. This is the after drop and the rescue collapse. Have you guys ever heard of it? I know you guys do Björgunasveit and Wofer and stuff like this. Is it something that you guys know?
No, not me.
No, not you. Okay. I mean, I would say this is probably one of the good things for you from that presentation. So when you have you have hypothermia, obviously your body's temperature is going to be cool, it's going to be down. And the after drop means that even though you take someone who is exposed to something cold, like let's say the snow or water, and then you remove them from the cold exposure, they might still cool down. So let's say we can measure their temperature in the bush, and then it's, let's say, 31 degrees, and then we take them inside, expose them, do our stuff, and then we take the temperature again, and it's like 29, and we're like, that's very strange, because now they're like in a warm temperature. And the idea is that when you are in hypothermia, your limbs are going to be cooler than your core temperature. This is where you're going to retain your heat. And if you rewarm people on their limbs and not their core temperature, their arteries and their veins from their arms and limbs are going to dilate. And then the blood from the core is going to go into the limbs, and the cold blood from your limbs is going to go into your core. And then you're going to cool down even more. And this is important because this might be important in patients who are kind of like cold, but they still had a pulse. They were kind of like on the limit of going into cardiac arrest. And then we rewarm them with only their limbs, and then they cool down even more, and then they go into cardiac arrest. So this is something that has been described many times in the rescue situation. So this is why we recommend to, when you rewarm someone, is to rewarm them on the core and not only on their limbs. The other phenomenon that is super interesting is what we call the rescue collapse, which is kind of like there's a bit of an overlap with the after drop. And the rescue collapse means this would happen if you're in a rescue situation and then you find someone who's awake. They might be a bit confused from the hypothermia, a bit shaking up from the avalanche, but they're still, like, you can still talk to them. They still have a pulse, and then they stand up, and then boom, they just collapse, go into cardiac arrest, and then boom, there's nothing much more we can do from them. And the rescue collapse is kind of like a mixed bag of many things. One of the things is that in avalanche or like in cold kind of like scenario water rescue, the pressure from the snow or the water on their body is going to maintain their blood pressure. And if you remove them because you rescue them, they're going to be even lower. And then sometimes what happens is that we ask them to stand up and then kind of like walk a few feet. So this is what's going to happen. That's going to decrease even more their blood pressure. It's like when you're dehydrated and you stand up quickly, you're a bit dizzy. So imagine this, but like multiplied. And then they say that there's also like a psychological component, that people are like super stressed, they're kind of like under the snow, their body is trying to survive, and then they see someone rescuing them, the kind of like the stress goes down, the adrenaline goes down. So kind of like this mixed bag of things that decrease the blood pressure, and people just collapse. So this is something, again, that has been described many times in rescue situation, that you have to keep in mind when you rescue someone, okay, from an avalanche, because they might look kind of like okay, but if you're thinking about they might be hypothermic, I would say I would just put these patients on the flat position for, they say, about 30 minutes, depending on the degree of hypothermia, and this is where we would rescue them, kind of like on the backboard or something, like more like a flat position. Was it clear? I talk a lot about these two concepts. Any questions regarding that? We're good?
Yes, we have one question.
Okay.
Erla?
Yeah, I was just wondering, so you would focus on warming the core then at that point and lay them flat?
Yeah. So one thing I didn't talk about is that, I mean, if they're mildly hypothermic, so going back to the revised Swiss system, Thomas, if you could go 2 slides before. I'm not saying that all the avalanche victims, they need to be, put flattish, but this is something we start worrying when they're more like into like 32 degrees and less. Some people say that even like 32, 35 degrees, we should put them like on the flattest position for about 20, 30 minutes. And the colder you are, the longer, they should just be on the backboard. And this is going to be hard because we cannot measure a temperature. So this is going to be a bit of a estimate on your clinical evaluation on how alert they are. There might be like a trauma to their head also. So, I mean, it's all of this is going to be more like a judgment call. But if you suspect hypothermia, I would say put them on their back, isolate them, and try to rewarm them from their core. Okay, you can go 2 slides. One more, perfect. Yeah, so one more. So if we put everything together, we talked about asphyxia, trauma, major trauma, and hypothermia. So when you're going to see an avalanche victim, you're going to be kind of like sailing into these 3 things. depending on the time, you know, if it was someone, I don't know, a village was taking away and then someone is cut like in their house, they don't have any trauma, but they might be cold. That's going to be very, there might be a bit of asphyxia if there is no like circulation of air. It's going to be someone very different from someone who was like skiing and fell like 200 meters with the avalanche. So you're going to kind of like have to sail within these kind of like 3 spheres of causes of major injuries. Next slide. And so avalanche victim, it's a race against time. We talk about asphyxia, trauma, and hypothermia. And if we kind of like try to imagine if we would be rescuing someone on the field, we use one of the way to use it, one structured approach would be the A, B, C, D, E. A would be meaning the airway, kind of like make sure their airway is open. B is going to be their breathing, make sure their breathing is okay. C is circulation, so if there's any trauma or bleeding. D is going to be more like disability, the brain, how alert they are. And E is going to be exposure, hypothermia. If you go next slide. So having a structured approach to an avalanche victim would be, okay, first step is making sure their airway is open, remove the snow from the mouth, expose the head and the chest. We expose the chest also, so if their chest was packed with snow, at least they can start breathing. And also if we need to do any CPR, we would be ready. In maybe more advanced scenario, we could always ask them, we could always ventilate them if we have any like back valve mask, if they're not breathing. The circulation would be, first of all, making sure that they still have a pulse. If not, start CPR. We could always connect if we have an AED, and also stop the bleeding by direct pressure or tourniquet. Disability, so again, check if they're awake or sleepy, kind of like thinking in the back of your head, okay, are they unconscious because of the hypothermia or because of the asphyxia or because of the trauma? And if it's because of hypothermia, kind of like how severe, how cold they would be based on that evaluation. We can try to wake them up, reassure them, talk to them, and check for signs of head injury and also like spine injury. And then E would be exposure. Again, not meaning like we strip them down on the snow on the glacier, but more kind of like making sure we're not missing any other injuries, head to toe sweep, splinting, and protect from hypothermia. One more slide, next slide. So when you're going to start dealing with these patients, as soon as you're seeing that victim, as soon as you're kind of like evaluating the victim, when you found them, you already have to start thinking about packaging this patient for extraction, okay, meaning evacuation, and also preventing hypothermia. And Iceland is very tricky because I mean, it's not super cold like in Canada where we get like minus 30 degrees during the winter, but it's always like a bit cold, but wet. And this is where you lose your temperature very quickly, and also with the wind. So even though it's not like super cold, you know, like looking on the thermometer, just being exposed outside makes you at risk of hypothermia. If you go next slide. So when you're going to extract someone, a victim, even though you're not thinking of hypothermia, let's say it was like 35 minutes, you find them, you're like, okay, Eric told me within 60 minutes, it's probably not hypothermia, why they're looking so bad. But still, one thing you have to understand is that when you're outside and you're a trauma victim, once your body temperature goes down, it's very hard for anybody to pick this temperature back. So that means it's very hard for your body to rewarm by itself if you're not packaged well. So one of the things that we talk about is the burrito wrap, which is basically a couple of layers. So the first layer would be like a vapor barrier, so something that wouldn't let the vapor, the temperature going, the heat, the humidity from the patient. So that would be, I don't know, like a small tarp or like these space foil, like these aluminum foil that we put the first layer on the person. Also, this is going to prevent the next layer, which is going to be something warm, like I don't know, like a duffel bag, not duffel, a sleeping bag, or like a down jacket to get warm. And then we usually wrap it with another tarp or big foil, that another vapor barrier that doesn't let the water goes in or out. So that's going to be like a first vapor barrier around the patient, so they don't lose their temperature from irradiation. They're not exposed from the next layer. It's not going to wet it. And then another layer, something that is going to rewarm them, like a sleeping bag, like these big, like rescue, what is it? Like something like yeah, I'm losing the word, but anyway, like a big layer that's going to rewarm them, and then something else like another tarp to prevent the patient from the outside, what we call the burrito wrap. And then we just kind of like wrap everything. I'm almost done. A couple of slides. So one thing that next slide. One thing that comes up often in these avalanche talks is the scenario of multiple victims, multiple casualties. Next slide. And if you're thinking about multiple victims, it's always a struggle, a balance between resources and victims. So how many people are buried, how many people could be victims, and how many people do we have for a rescue? And this is hard. There's not much data on what to do. Even in the ER, when there's multiple victims coming at the same time, even though we have a lot of resources, we're still struggling with these scenarios. So you're really trying to do your best and kind of like helping the most people that you can do. And if you go next slide, there's been some studies from Avalife, which made some kind of like simulation scenarios. And what they calculated is that when there's multiple victims, they say that you should do a CPR for about, for people who've been buried more than 1.5 meter under the snow, you should do about CPR for about 6 minutes. And then by that time, if after 6 minutes, there's no return of circulation, so if there's no pulse, maybe you should consider stopping and trying to look for other victims who might be salvageable. Okay. And this is, I would say these are a very tough situation to stop doing any medical interventions on the field and just to move on and try to find other people, because you might not find them. That's might be one thing. But you're trying to struggle between the number of resources that you have and the victims. Next slide. Yeah, and to prepare, ask Sydney. I'm not sure if she's here. Hi, Sydney, if you're here. A question. And one question she had is that what's in my bag? And if you go next slide, and the answer is what's in my bag is not what should be in your bag, in the sense that kind of like talking about like medical stuff. What's in someone's bag is always different. Depending on their capacities, their medical knowledge, the length of the trip, where they're going, how much you can do with little. And as you know, as outdoorsy people, a bag is always a question of compromise, because you're going to need to carry your stuff up and ski down, or you're going to, if you're on the snowmobile, maybe it's going to be a bit less of a problem, the weight. But yeah, bag is always a question of compromise, of cost, of space, of weight, and also of medical knowledge. And the more I know the more, as a physician, the more I can do with little. So with time, my bag is kind of like shrinking more and more. If you go next slide. So what's in my bag is basically not a super big medical kit, but at least something to do just mouth to mouth, with a layer, ventilation, stuff to splint. If it's like a gel for someone with their sugar would go down, a lot of stuff to dress. And also I carry a emergency shelter, like this Rab super light, which I really love. It's great to make any like small pause to eat, also to rewarm yourself. And if there's a victim, it's super easy. You can just wrap that around that person. It's super light and easy to carry. So that's what I would carry in my winter bag. Next two slides. Yeah, next and next again. Yeah, talking about like prevention. Yeah, so as you can see, the prognosis of an avalanche victim is not super great if you're buried, if your head and your chest is buried under the snow. So this is where prevention and making sure someone doesn't fall into an avalanche becomes very important. And I think this is why I find this so great to talk about this evening, is that I think a lot of it goes through you, like policymakers and people, kind of like making the avalanche kind of like surveys and maybe like moving roads and things like this. So I think you have a bigger impact than you might think. So a couple of things. The beacon showed in studies that it shortens your avalanche rescue time from 2 hours to 20 minutes. Okay, so someone would have a beacon of more chance of being found within 20 minutes versus someone who doesn't. And then when we talk about asphyxia, that after 35 minutes, if your airway is packed, you are and you are into cardiac arrest, you're done. So this is where it can save a lot of lives. The other thing is the avalanche airbag, which is very nice, but also very expensive. Heavy, it takes a lot of space. If you're moving around and traveling, it might be a bit of a problem. But still, this showed that it decreased mortality by about 50%. So not insignificant, so quite interesting. Next slide, and this would be my last. Yeah, Thomas, if you could move one slide, please. Yeah, I think Thomas went to sleep. Up.
Thomas, ertu þarna?
Yeah.
Tack.
So yeah, one last thing I want to talk about is a post-traumatic stress disorder. So basically, this is a kind of a psychiatric condition when someone is exposed to a life-threatening situation, or like a near miss. They were an avalanche trip in front of them, but they're okay. These people can start maybe experiencing kind of like reenacting in their head and fear, a lot of stress from that. So the big kind of like stereotypical is, they would think a lot about that situation and be very anxious. And where it's important is that this has been associated with like depression, substance use, meaning more like alcohol use or drug use, and even suicide on the long term. And why it's important is that sometimes it can be a bit subtle. Someone who has like PTSD, they can be a bit more, like retracting and avoiding situation. So still feeling these things, but maybe retracting from the society or from their family. And it's important because the treatment are quite good through psychotherapy, but they need to be started early. So as people from the industry, you might have experienced it, or maybe someone of your worker, you know, could have been like in a near miss, or like kind of like in a situation where, yeah, they were caught in an avalanche. So I would say if they were caught in an avalanche, or if they were like very close to one, I would kind of like screen for post-traumatic stress disorder, and also refer them to their helsingärsla if they have any symptoms. And it's important also because kind of like preparing on the presentation, what I found is that we have some studies from Iceland, from Flateyri and was it Sudavik, the other village, that 16 years after the avalanche from 1995, when they did like phone interviews, about 15 to 20% of the people still had like PTSD symptoms. So this is quite, yeah, so like the survival, or people were like were outside of the village, or were, you know, caught in the avalanche and survived, like 15 years after, there was still a lot of PTSD symptoms in that community. So something to think about. Next slide. So, or maybe the one before, I'm not sure. Before. So yeah, so I guess I'm done. If you, yeah, if you have any question, and I'm very sorry about the communication technology problem. I'm very glad to still be able to connect from Canada.
I got one question for you, Eric. What do you think about this possibility of like when you resuscitating for 5 minutes and then you stop for 5 minutes, like to move the patient, if you need to get the person from A to B because, you know, the helicopter cannot reach, or the snowmobile or something. Do you have any opinion on that?
Yeah. So so what you're referring to is that there's been people saying that in situation where you need to evacuate someone, and they're in cardiac arrest, and then you need to evacuate someone. Let's say they are on the bottom of a like on a crevasse, or it's a very tricky situation. You extract them from an avalanche, but the helicopter is going to land 100 meters from now. And now we need to do CPR, but we need to move also. So this kind of like this compromise of we need to move, but we need to do CPR. How are we going to do this? So some people have recommended the idea is that you could stop CPR for a brief period of time, let's say 5 minutes, and move that victim, and then resume CPR again, and then stop for 5 minutes, move that victim. If I remember correctly, they talk about most of it, they recommended about for hypothermia cases. And the idea is that they recommend doing this, and the colder you are, the more you can do it, because when you're cold and hypothermic, your body is already like in a conservation state. So people sometimes who survive cardiac arrest, we would cool them, even though after cardiac arrest in the hospital. So the idea is that, okay, like they are in cardiac arrest, their heart is not pumping, but at least they're preserving because they're cold. So let's take that time window and move them to evacuate them by chopper or whatever, and rappelling down or taking them off a crevasse. So that's something people can definitely consider. And I think what they recommend is that if you're very cold, like severely cold, they say I think 5 to 10 minutes of pause to do CPR to move that victim. And if you're a bit less cold, they say about 5 minutes. So that's, I would say this makes sense. I mean, you're in a tough scenario that you need to do CPR, but you also need to evacuate that victim. So it's like, damn if you do, damn if you don't. Huh?
Thank you so much, Eric, for this. So like in terms of like what you just said, would you recommend then cooling patients if you know that Like, would you put like snow inside their clothes or
Definitely
something?
not. No.
Okay, because we know
No, definitely
there was
not.
okay. So I explained my question. There was a scenario in like Hlíðarfjall a few years ago where there was like a doctor pretty early on scene, and he like cooled the patient down because and I think it saved his life ultimately. But yeah, you don't recommend doing that like in the field if you're not a professional.
Yeah, I mean, yeah, I heard of that case also. I mean, medicine changed, okay? So 10 years ago, we would cool everyone down after a cardiac arrest. Let's say we're not talking about avalanche victims. You're driving a car, boom, you have a cardiac arrest. And then we resuscitate you, you survive, and then we bring you to the Gjörgæsla, and then we cool you down. 10 years ago, we would do this almost, like all the time. And then we're like, okay, so should we cool them to that or that? I mean, it was not clear. And then now we have more evidence that says that, yeah, we probably don't have to cool them that much. We can probably just cool them like that little, and it's going to be fine. So I think at that time, I think this was kind of like the rationale is like to cool that person to, again, go like in a preservation state. I mean, I definitely understand that, but I would not recommend it because, because hypothermia also has its problem. And if you have hypothermia and trauma, I didn't talk too much about it, but it's very bad. Like your body that cannot make clots in your blood. So I would say just do like a good burrito wrap, avoid hypothermia, and just move on. Yeah.
Thank you. So are there any more questions for Eric? No. Thank you so much, Eric, for taking the time to do this. And it was very informative, definitely.
All right. Thank you so much.
You're getting a lot of applause. Erla, do you want to say something? Or no?
No, I was not put applause.
Yeah.
That was sorry. Thank you so much, Eric. This was awesome.
It's been my true pleasure, and if you guys want any other help for any other project or a presentation, I'm always available, and we're going to Iceland again this spring. So I'm always ready to help.
Thank you so much.
Yeah.
Okay.